I would like to welcome everybody to today's BC webinar, which you are, where will be 3 hours in length. My name is Belinda, as stated, and today's webinar marks the release of the Office of Senior Advocate Long-Term Care Resident Family 2017 raw data. I would like to begin the webinar by acknowledging the ancestral, traditional, and unceded territory of the Musqueam, Tsleil-Waututh, and Squamish nations, from whose lands we are leading today's webinar on. Now, you may have noticed that I joined this webinar, and that's just to avoid any background noise during the presentation. I would advise you to use the chat box to share any questions that you may have, or to unmute yourself to ask your questions via the microphone or the chat, whichever you prefer. So also this webinar is being recorded and will be available on the BC PCM website, along with the BC Support Unit website and the PubData BC website. Also, following today's webinar, you guys will receive an email with the material from today's sessions, including links to the recording as well. So I'm going to pass it on over to Lena. We can begin today's webinar.
Thank you, Belinda. And it is really my pleasure today to have all of us gathered today and to have the opportunity to introduce Isobel Mackenzie, BC Seniors Advocate. This meeting and this survey would not be possible without Isobel's vision and her passion for giving voice to frail older adults living in residential care, about giving us their assessment of the quality of the care and their health-related quality of life in long-term residential care. Isobel has over 20 years of experience working with seniors in home care, in licensed care, in community services, and in volunteer services. Isobel led BC's largest not-for-profit agency, serving over 6,000 seniors annually. In this work, Isobel led the pioneering of a new model of dementia care that's become a national best practice. She led the first safety accreditation for home care workers, among many other accomplishments. Isobel's been widely recognized for her work and was named BC CEO of the Year for the not-for-profit sector and nominated as a BC Provincial Healthcare Hero. I'm pleased that Isobel, BC Seniors Advocate, and someone who has become my friend, was able to join us today to provide an overview of her vision for what will forever be known in British Columbia as Isobel Mackenzie's survey. I've also asked Isobel to give us a sneak peek into the next steps in assessing quality and safety of care in residential care in BC. So Isobel, over to you.
Thank you, Lena, and I am going to try to share screen here, so just a second. That's what I want to share, I think. Slideshow. Okay, so let me ask, can I get a thumbs up from Belinda? Are you seeing my slideshow on the screen?
Yes. Great.
Okay, brilliant. Let me just get something happening here. Okay, there we go. All right. So the residential care survey philosophy, now just a second here. I have to get you guys off the screen so I can read my slide. Okay. So one of the driving forces behind this survey was when I first assumed this office, and it was the first office in the province, the first in Canada. I heard from a number of people around British Columbia, both seniors, their family members, and the community at large, about a number of issues facing seniors. And one of the issues that I heard a great deal about was long-term care. And we have a number of measures in long-term care that we think are measures of quality. So we measure things like falls and pressure ulcers and antidepressant medication and antipsychotic medication and amount of PT, OT, and their depression scale rating and their engagement scale rating. And we externally do these assessments and we spit out what we think indicates good quality in a care home. But what is missing, I think, in the picture, or thought in the picture, was really what matters is how do the people who live there view the quality of their life and the quality of the environment that they're living in, because really that's what matters. So, and we don't do that in a systematic way. There's a sort of a patchwork of surveying and that happens, that is administered by care homes directly to their residents, maybe reported, maybe not, to health authorities. Anybody engaged in the accreditation is required to survey, but how they survey, the frequency, whether they survey the residents, the family members, whether they do it as a census survey, whether they do it as a sample survey, is all left up to interpretation. And we also, I was surprised to learn that some jurisdictions, specifically in our next door province of Alberta, had taken the approach that really we're only going to survey the family members because the residents cannot meaningfully participate in the survey. And I was quite taken aback by that, frankly. So my philosophy, and it's a philosophy grounded in working with seniors for about 20 years before I came to this role, and working with seniors primarily in the home care setting, although I have worked with seniors in licensed care settings and assisted living settings as well, is the recognition that people have opinions to a large extent for a long period of time in their aging journey. Many have opinions, valid opinions, for the totality of their journey. And many have opinions that are still relevant and can still be obtained as they journey through dementia. And we can have a diagnosis of dementia. We can be incapable of managing our financial affairs, but we can still know whether we like the food we're getting. We can still know whether we're getting a bath or shower as often as we want. We can still know whether we feel the people around us are providing us with meaningful conversation. And so, yes, we need to go and we need to ask the people in these care homes, what is their quality of life? And every voice needs to be heard. So the other philosophy of this was we were not going to allow clinical staff or chart notes to determine who was included or excluded in the survey. We weren't going to say, oh, you know, we'll decide who's able to participate in the survey, or we're going to eliminate from the survey everybody whose CPS is 3 or greater, or 2 or greater, or some such measure. We were going to approach everybody, and the only exclusion category that would be allowed would be that they were not able to complete the survey after 3 attempts. So yes, we recognized that there would be a number of people who would not be able to participate, and there would be some people who would be able to participate but didn't want to participate, and so that would be allowed. The exclusion criteria we did impose for reasons of practicality were not based on a person's perceived cognitive ability to respond to the survey. We excluded based on purple dots. So that is somebody who has been identified as potentially violent and aggressive behaviors. And that was done really around the protection of the person administering the survey. It was a small number of people, and Lena will go through some of these details later. We also excluded people who were palliative. So again, we did not want to intrude on that precious amount of time that people have with their family members when they are in the last days and weeks of their life. And so we did not survey those residents who were designated as palliative. And also those who had been just admitted to the care home. There was 2 reasons for that. Number one, we wouldn't be able to link it to inter-eye data. And secondly, that may not be the best measure. And Lena can, I think it was within 30 days. If they'd been admitted within 30 days, they weren't surveyed either. So those were the only reasons we excluded people from the survey. The other philosophy of the survey that I had, and there was a little bit of head-butting with some of the survey gurus back east, was that I was not in favor of presenting the data in predetermined themes. where we would package up a series of answers into a theme, and we would give a response to the theme. And the reason for that, and I would challenge you all to think about that, because I know that we do often do that, is that the individual answers can get lost in the themes. And that was demonstrated when we looked at the results of this survey and found that the question that had the highest negative was the bathing question. Do you get bathed? Do you get a bath as frequently or when you want? It had the highest negative rating, 60-some%. That question was wrapped in a theme that would have had a much more positive response. And so we wouldn't necessarily have been aware of that if we had focused only on the theme. So that was another guiding philosophy for this survey. Open, transparent, and accessible process. So we engaged with a group of people for about 18 months. Lena will go over in more detail what we did. Everybody knew the questions we were going to be asking. It was publicly known that the survey was happening, and the results of the survey were made available. So there was the complete survey with every question, every answer available to the public, and now we're expanding on that by making it available, the data sets available to researchers as well. And so, and we also combined that, and Lena will go over this more, with a rigorous design survey, measurable and comparable, so that the results would be considered valid, not just by the people who live there, whose voices we have heard, but also by the expert community on patient-reported outcomes and measurements. Accomplishing the survey, expert leadership, and that is Lena. So having the vision actually is the easy part. Realizing the vision is the difficult part. And Lena's leadership on this was nothing short of phenomenal. My job was just to keep saying, no, keep going, keep going, keep going. And what she accomplished in terms of the mobilization of volunteers, and when you think about standard survey administered to 300 care homes, 28,000 residents, 10,000 responses received from residents, 10,000 responses received from visitors. It really was a phenomenal achievement. And that really is a testament to Lena and her leadership. Collaboration was also required. Again, we had the expert group of people, which did include representation from families who had loved ones in long-term care, but also all the unions, all the industry associations representing the contracted providers, the public providers, the health authorities. Everybody was gathered around the table to come to agreement. Now, interestingly enough, despite that 18-month process and getting agreement from everybody, when the results started to roll in, suddenly some of the industry associations were concerned about the survey. They weren't concerned until they saw some of the results, which is an interesting issue that I think needs to be thought about a lot more. Community engagement, 800 volunteers, 25,000 hours. That was a phenomenal accomplishment as well. And as I said, 10,000 residents and 10,000 family members gave their time. The residents, I don't think any of them could possibly have completed the survey without spending at least an hour with the surveyor. Many spent more than that. And the family members, it was a long survey. And so family members had to spend the time to fill out the survey and to submit the survey. And it's a testament to how much they care about the experience of their loved one. Progress on the findings. This is not the right slideshow. Care hours have been increased slightly. And I believe when we do our monitoring, we are going to find it is the 3.36 hours of care. Staffing continuity. has been increased. It's not through Bill X. That X was supposed to reflect the number, but the government has introduced and passed legislation that effectively eliminates the ability of care homes to change their staff when they change their contracting model. So that is going to give greater continuity of staffing, which was a large part of what we heard from residents. They need more staff, and they need the staff that are there to be more consistent. So we have seen action on those two issues that were raised. We need accountability to monitor the funded hours of care. That work has started. That work has not yet been completed. We have seen some recent COVID initiatives, pay leveling and single site orders, that are going to address some of the issues that were raised in the survey as well. And we have started to work on our next survey, which will be in 2022. So the idea is that the survey is repeated every 5 years and the progress measured. Now, I'm just going to hit this to see, yeah, I apologize. The slideshow that I thought I was sharing had a slide with the recommendations on it. So I'm not sure why that, I shared the wrong slideshow, so my apologies about that. But the report did come up with a number of recommendations. Essentially, the recommendations were, we need to increase staffing levels. That has happened to a large extent. We need to increase the continuity of the staffing so that the staff that are there will know the resident better. That has started with a number of initiatives that have been undertaken. There we go. I don't know if you can see that. Okay, has somebody captured my screen?
Yes, Lena is now sharing her screen.
Okay, so Lena has the correct last slide. So increased staffing levels in care facilities, so check mark, that has happened. Increased flexibility around when and where services and activities are delivered. We won't know the progress on that until we go back in the field and survey 5 years later. Increase activities for weekends and evenings and create more meaningful experiences overall. Again, we will know if there's been progress on that when we go back to survey in 5 years. That was a message that came out loud and clear from residents as well. Provide better physician care, either through GPs or increasing the role of nurse practitioners to improve care. We can measure part of that through other means, but from the perception of the resident, again, we won't know that until we measure progress 5 years out. Examine opportunities to improve the mealtime experience. The interesting thing is that the #1 complaint about meals was that they weren't happening when the resident wanted, versus what we thought we would find, which was complaints about the food itself. And this was a theme that resonated throughout, which was the lack of autonomy and the lack of spontaneity that is allowed in the care home. And as you would expect, when we matched responses to Inter-Eye data, we found that those who had greater mobility and less restrictions on their cognitive function and their physical function were the ones who found the activities less meaningful, who found less engagement with the people around them in the care home. And I think that invites a much larger discussion in long-term care, not just in this province, but across the country, which has been our move to the complex care model. We are mixing together in one site people who have a wide-ranging level of ability or disability, both physically and cognitively. And it's not as successful as we might think. And that came through in many of the answers around belonging and engagement, around having people, they have things in common within the care home, et cetera, et cetera. provide ongoing education for all care staff on the importance of resident emotional well-being, and focus on developing skill staffs and supporting this important aspect of care. And that, again, we're very task focused, and the tasks are getting done for the most part. It's the totality of the experience in long-term care where we're missing some of those important connections. Health authorities require facilities to administer the Inter-I Self-Reported Quality of Life Survey every 2 years and publish the results. That didn't happen. Again, we talk a lot about wanting to hear people's experience and wanting to learn from it. But we, in long-term care, still default quite a bit to we know best. I was quite struck by a focus group put together of envisioning long-term care, and people started talking about, you know, we need pubs in long-term care and daycares in long-term care, and we need, nobody in the room lived in long-term care. Everybody in the room either worked in it or had a business interest in it, or a policy interest in it. But, and what I was struck by is that isn't what the people in our survey said. What our people in our survey said who live there and their family members, loud and clear, we need more people here. We need more people to help us eat, go to the toilet, have a bath, and we need people to talk to us in a meaningful way. And I would like to be living with people I have something in common with. And that's where we're falling short. And so I think we need to look at how we address those fundamentals before we move on putting pubs and daycares in our long-term care centers. The eighth one, foster greater engagement with family members in 2 key areas, one of them very prophetic, family councils and hand washing. So remember, this survey was pre-COVID and pre-focus on infection control, but certainly engagement with family members. We need, I think, a stronger support and network for family councils. They are pivotal in our ability to ensure that we're meeting the needs of our residents, that we are resident focused, and they are significant assistance in the, meaning assisting us in the provision of the care. We are, I'm in discussions with Lena. We're going to be actually going out and surveying family members in the next couple of months around their experiences with the COVID lockdown, and we're going to also be surveying care home operators around their experiences with the COVID lockdown as it relates to the family members not being able to come in anymore. We've had people who visit daily who were not able to visit for 3 months. And so it will be interesting to see what the impact of that has been. And I think we're going to be quite surprised at how significant family members are to the provision of quality care. So okay, Lena, I've got my hands off here. I'm finished my presentation. We can go back. I'm happy to answer any questions anybody might have, and or turn it over to you, Lena.
Well, I wonder, Isobel, whether we should move along, and if questions come up after I've talked about implementation, people can pose those to both you and me.
Okay, that sounds good. That sounds great, Lena.
Okay. So Isobel will stay as long as she can, and so I'm grateful, Isobel, for you set the stage for us today. And what I'm going to be doing now is providing a whistle-stop tour as to what Isobel described as the 18 months of planning and implementation of this sector survey. And I should really have a slide that says that they said it couldn't be done. But the reason that we did accomplish this, and Isobel and I are going to sound like a mutual admiration society here, but really it's a testament to Isobel's unwavering vision. And if you could have been a fly on the wall during our meetings and our telephone calls, you would have heard Isobel say, Lena, I want every resident living in publicly funded long-term care to be surveyed. And I would say, Isobel, you mean we could do a random sample, right? We don't have to interview every resident. And she would say, no, every resident. And I would say, you mean publicly funded in the private facilities as well, because there's contracted facilities? And Isobel would say, no, every single resident in every publicly funded long-term. It was her unwavering vision that was that is a testament to why we were successful. And so if you look at the numbers, we went into 292 care homes in the province of British Columbia. And looking at the eligibility criteria, which I'll go over in more detail, we approached 22,162 frail, older adults, some with cognitive impairment, and we engaged in a full interview, which, as Isobel described, often took an hour and a half, in a respectful way, with 9,812 of those residents, so for 45% response rate. And we then matched each one of those residents to their most frequent visitor, who was sometimes a family member, but not always. So if the family member didn't live in town, if the family member lived outside of the country, we asked each care home to identify who visits that individual the most frequently, and that was the person who received the survey. And of those, we accomplished almost a 50% response rate. So we conducted 128 full-day training sessions with the 854 people that we recruited, screened, recruited, trained, deployed, and supported to conduct the interviews with our residents. And I'll talk shortly about the volunteer model that we put in place. But what I do want to say is that if you look at the number of volunteer hours that were logged conducting the interviews for Isobel Mackenzie's survey, 25,219, that equates to 12.9 FTEs, full-time equivalents. So if these volunteers had worked over a full year, if we had used that as the calculation, it would have been 12.9 full-time equivalents, and that would have cost us over $650,000 in staffing costs. So how did we do this? The first step was stakeholder identification and stakeholder engagement. So Isobel and my office together put together an expert consultation group that, as Isobel indicated, included most frequent visitors, family representatives, a range of community groups, including Family Caregivers of BC, Community, which represented the queer, gay, lesbian, transgendered population, the unions. We took the risk to engage with leaders in the BC Nursing Union, the Health Employees Union. We had health authority leaders, clinicians, researchers, the BC Care Providers Association, and they provided advice on every aspect of the implementation of this survey. We also were connected at the hip with the Health Information Privacy and Security Council of British Columbia, which is representative of the Ministry of Health and all of the health authorities, and the Office of the Privacy Commissioner. From a privacy perspective, this was a very complex survey, and we had to work very closely together. And then, as indicated, we made the decision to use a volunteer model, and so we developed a volunteer resources management subcommittee. And what we did was we harmonized and standardized a provincial approach to the screening and the recruitment and the training and deployment of volunteers across the province. And then we recruited the interviewers. And what I want to say about that is it was a huge with capital H-U-G-E, community engagement effort. And that included media releases as well as engagement with local communities at all levels. And that has paid dividends. Rick Sawatzky and I conducted focus groups for another purpose across all of British Columbia and each of our health authorities. And at every table that we brought people together, there were people who put up their hand and said, yes, I know what a PREM is. Yes, I know what a PROM is. I was involved in the Seniors Advocate Survey. So step 2 was the selection of survey instruments and the customization of those to meet the information needs that Isobel had and for the province of British Columbia. So we developed criteria for tool selection, conducted a literature review and an environmental scan, assessed the quality and fit of all the tools that we found against the selection criteria for BC, and in the end, we made the decision to use the International Resident Assessment Instrument, one of their tools, or two of their tools, the resident and family surveys, which were the patient-reported experience measures, and the VR12 patient-reported outcome measure. We then conducted a gap analysis using the Barrel Institute white paper on long-term care, which had just been published at the time, as well as the Ombudsperson's report on seniors care in British Columbia. Defined missing themes or gaps. We did research and consulted broadly. For example, we engaged with the General Practices Services Committee of the Doctors of BC around medication and physician visits, confirmed the suitability and cognitively tested the items with residents and family members before finalization. I'm not going to go into the work that we did on the adaptation of the VR12 prompts. Rick will be facilitating a session of examples, and this is an example we'll present to you, and Dr. Rozanne Wilson will speak more about that. Then, as Isobel mentioned, we defined inclusion and exclusion criteria for the survey at the level of the resident and at the level of the facility, and I'll talk more about that, and we conducted the privacy impact assessment. And so the selection of the inter-RI resident and family tools was based on their psychometric properties, the ability to do benchmarking nationally and internationally, and then the parallel aspect of wanting to conduct a matched sample resident and most frequent visitors, and then the VR12. So this slide provides an overview of what we attempted to measure using the experience and the outcome surveys, and looking at what was included for the resident and the most frequent visitors. And what I want to say about the most frequent visitor survey is that it was not administered with the intent to be a proxy. We wanted to explore to the extent to which most frequent visitors could in fact provide responses or to assess how similar they would be to residents' own assessment. But we also developed and included questions that looked at the most frequent visitors' own experiences in terms of how they were welcomed in their observations in the care facility. So I won't go into this in detail. Ben will go over in more detail the data, but these are the dimensions, and you can see by the asterisks that we developed some additional questions for British Columbia. One of the things that's really important for you to be aware as data users is that there are restrictions and obligations of use of the Inter-RI survey instruments. BC has a license, and we will load up to metaspace on the Ministry of Health metadata space the details of this, but the most important piece is that this is a copyrighted tool, so you require a license to use it, and even if you are doing secondary analysis using the data, you are not permitted to publish the full text of any of the questions. Our Inter-RI license permits us only to publish edited, paraphrased text fragments, and those are located in the technical report for the survey, which will also be uploaded to metaspace. So the methodology was, Isobel wanted every resident survey, so a census methodology for the resident survey and a matched sample with the most frequent visitor, in-person interviews for the residents, and for the most frequent visitors, they received a mailed survey with a paper copy and an online option that included a URL and a unique access code. So again, the potential respondents were every resident in a publicly funded bed in 292 care homes that were either directly owned, managed, and owned by the health authorities or contracted by the health authorities. And those contracted ones could be either not-for-profit or for-profit private care homes. So here are the inclusion criteria at the resident level. Isobel has already indicated cognitive level. Our interviewers were blind to that. They had a list of the residents and they approached everyone with very few exclusions. All residents regardless of age, all residents who had a completed RAI MDS 2.0 clinical assessment completed, and Isobel, not 30 days, within 14 days of admission to a long-term care home. We did consider whether there would be too much turmoil in facilities that were scheduled to undergo renovations, but we decided not to unless they were scheduled for closure and had provided notice of intent to do that. Residents in temporary beds, owned and operated, and in publicly funded beds in private facilities were also included. Exclusions were seniors living in group homes and family homes, not the care home, long-term care sectors, in designated respite beds because their experience might only be a day or two, in designated convalescent beds, again because of the short length of stay. We did not want to burden residents at end of life in palliative care beds, residents that were in flex beds. And then Isobel already described the purple dot, and what I want to emphasize here is these people were only excluded if the facility coordinator on the days that the volunteer interviewers were on site deemed the resident to be a risk to the volunteer interviewers. So if they were having responsive behaviors on that day. If the facility coordinator said, Mrs. So-and-so has a purple dot, but she's having a really great day today, and so I'm going to go down with you, introduce you to the resident, and let's see if we can conduct that interview. So even this was a limited exclusion. So we did exclude people on tertiary mental health units. Residents, of course, had the right to decline or refuse to participate, but I can tell you that it became kind of like the event of the day. When volunteer interviewers were on site, somebody had an interview, they enjoyed the interview, they told two people who told two people, and soon there was a lineup of residents wanting to be interviewed and to have their voice heard. And then residents who were unresponsive or unable to participate, they were approached 3 times, and if they were asleep, we came in another day or another time. But if they were unresponsive and unable to participate after 3 encounters, the interview, of course, they weren't interviewed. And then the most frequent visitor survey I already mentioned was mailed to people. So here is a data dictionary of the information that is included at the record level with each resident's responses to the evaluative questions on the survey, as well as their narrative comments to the open text questions. So resident first name, last name, medical record number, PHN, a language code that helped us in planning purposes because we administered the survey in 10 languages, the room number, bed number where the volunteer could find the resident, their gender, their date of birth, the facility name, the admission date, and every single one of the clinical assessment indicators on the RAI MDS 2.0. So all of that information is available for secondary analysis. And then with the most frequent visitor, first name, last name, their address, language code, facility name, and not their PHN, but the resident PHN, so that the most frequent visitor record could be attached to the resident record, so it would all be available for secondary analysis. So the yellow items are there for you for secondary analysis and potential linkage to other clinical and administrative data sets in the central data warehouse of the Ministry of Health Ideas. And the turquoise ones were the only data elements that were provided to the volunteer interviewers. Okay, so how did we do this? A huge volunteer engagement effort. And again, this is Isobel's vision here. She said, Lena, why don't we do this like a political campaign where you have sort of a campaign manager in each region? So we followed her advice and we hired a team of what we called regional engagement leaders, 1 per health authority, who were responsible for volunteer management, recruitment, etc. And they came with amazing background. Jessica came with experience working with the United Way. Tina came with experience working with the Alzheimer's Society. Sarah came with experience working with diversity. And I set the stage right from the beginning saying, individually we fail and together we succeed. And we might redeploy you, have to help each other, etc. And that proved to be very successful for us. So as I mentioned, we developed for the first time in British Columbia a centralized and standardized approach to a harmonized approach for volunteer recruitment, screening, training, and support. And we selected an online volunteer database that was a better impact. So the engagement of the volunteer interviewers, we developed a survey website. It's still up and active. And it is the repository for all of our training materials, all the information about the project and while we were in the field, what weekly updates and articles. We developed a one-day in-person training session, and all of the training videos and the handbook are on this website. The Better Impact system ran in the background with a secure access code for volunteers to go in and self-schedule themselves. We predicted based on number crunching that we did, how much time, how many volunteers would be required in each facility. As each facility opened up, we put out the call, volunteers self-scheduled and were assigned. And then we provided ongoing province-wide communication with monthly volunteer newsletters and emails with key messages. So I really encourage you to go to www.surveybcseniors.org. You can see all of our training videos there, a welcome video from Isobel, a video on how to conduct a structured interview, a video on communication with people with dementia, and a video on infection prevention and control. The training video on how to conduct a structured interview has now been taken by the province of Quebec, and they've dubbed over my voice with subtitles in French, so that's kind of fun. So the volunteer training was one-day mandatory training. We did, of course, have people who didn't, quote unquote, pass the training. They each had to conduct a mock interview before passing at the end of the one day. And if they didn't pass, they were deployed in other ways. It was a respectful process, but not everyone was deemed to be a good fit. The resident interview was conducted in person. It was structured. The trained volunteers were independent from the facility. They couldn't have volunteered there before. They couldn't have worked there before. They had to be independent. I already mentioned quantitative and qualitative data were recorded, and the 10 languages that we conducted the survey in. And then it was really just engagement and monitoring, developing the relationship with the RELs, with the volunteers, a lot of appreciation with milestones at 30, 60, 90. We had one volunteer that did 120 hours. And then the parachute assignments was, we used a project management technique called crashing as the project went forward to try to accelerate our progress in the field, and parachuting meant that we had certain volunteers who demonstrated a strong commitment to the project that we parachuted into communities where we had difficulty recruiting, and they took on that responsibility for interviewing. And then we conducted a volunteer experience survey. So stakeholder engagement was key, and I've highlighted here that we couldn't have done the work without any of these different groups, but we really needed somebody designated at every one of the 292 care homes to be a facility coordinator and to support the site team. So this is what we did: identified a care home, notified them of the potential date, confirmed those dates with them, held a 1-hour planning call with the facility coordinator, got the data file submission, so all those data elements that I showed you that we needed to collect, then printed the materials with the resident names on them, then had the volunteers assigned, recruiting, training, and then the survey started. So in phase 1, we engaged 20 care homes who put up their hand and said, pick me, we want to be first, with 1 to 2 care homes being brought on board each week across every health authority to give us experience. And it was organized chaos, and we learned a lot. We learned about how to hone that facility call, about supporting the facility coordinators. We realized that the data request for the for the Interi MDS 2.0 clinical assessment data was too laborious, so we made an own data request to CIHI so that that information was sent directly to our vendor. I changed the format of our weekly check-in with our team. I realized that it was becoming a session where only the negative was being brought forward. I can't do this, I'm struggling with this. And I changed the format so that every weekly check-in that we had with the REL, They had to present one thing they were proud of and that was going really well, and one thing they wanted input from the rest of the team, and that served to work really well for us. And we developed targeted volunteer recruitment strategies, especially for volunteers who could speak alternate languages, and supporting our volunteers. Oh, I mentioned here, it came to our attention that volunteer interviewers were being, not a lot, but we got an example or two of allegations of abuse, and then we worked together with Isobel and her office and the public trustee to develop a process for how to address that. So when we were operating at full tilt, we had 25 to 55 care homes in the field simultaneously being surveyed, with 20 to 30 data file submissions coming to us on a weekly basis, with 10 to 22 more care homes in the planning stage, and 3 to 5 full day volunteer training sessions happening. And that was happening on a weekly basis. So just to show you how we did the sort of number crunching, here's all of the care homes, you know, on these massive spreadsheets, the location, you know, how many volunteers we were projecting they would need based on the number of beds and the projected number of residents, et cetera. And then we just had to keep the momentum going and going and going and going. And so we had, you know, a lot of things in place to try to keep the inspiration being contagious, and contagious might not be a good word in the COVID environment, but in 2016-17 when we did this survey. I already mentioned that we crashed sites and brought volunteer teams together, recognized those volunteers that had done amazing commitment by giving them the opportunity to parachute into other communities. And then we started developing the site level report. No comparisons with anyone else. That was going to be Isobel Mackenzie's job, to present the comparisons at you know, facility, health authority, and provincial levels. But we wanted to recognize the effort at the local site to invite our volunteers in. And so they received their reports within 30 days of completion of the resident and 30 days of completion of the most frequent visitor surveys. And with that, we produced PowerPoints for them. So we gave them their reports, but then we imported the key results into PowerPoint. You can see it was generic, so they filled in their own name. We invited each site to an information session or a group of sites and kind of went over their results. We provided weekly information sessions and helped follow up if they needed. And then the big event happened on September the 17th when Isobel Mackenzie released the results. We had 4 locations across the province that were simultaneously connected by the media. In Vancouver, we filled the entire Italian Cultural Center with volunteers who came to celebrate the efforts that they had put into the survey for Isobel and our office. And we trended on Twitter. So we were in Vancouver, Kelowna, Victoria, and Prince George simultaneously, with our regional engagement leads in each location, and the media paying close attention to Isobel's recommendations. So reflecting on the vision, I don't know, Isobel, if you remember this, but what Isobel said is, this is not the voice, but the voices of residential care, as the diversity of opinions is apparent in the results. Together, these voices are telling us that our residential care system has some good aspects, even very good for some. But taken as a whole, we need to do better, and in some cases, we need to do much better. And so here's a link to Isobel's full report, which is posted on her website. And then you'll get these slides as well. This was a video that was put together by Isobel's office, where we had volunteers talk about what it meant to them to participate in this survey. And I think you would find it really heartwarming and informative to watch and see what we accomplished in British Columbia by engaging 854 people who learned a lot about what it would be like to live in residential care, what it was like to go into a care home and to listen to these rich stories. And I can tell you personally, when I was training some of the interviewers and our team, I had an individual that I spoke to for about 10 or 15 minutes, just, you know, warming up before I started the interview. And then I got to a question that asked, do the staff here know the story of your life? Would you say never, rarely, sometimes, most of the time, or always? And he said, never. And I stopped and I asked him, what do you mean never? You've just told me this rich story. And he said, oh, I don't want to bother them. They're so busy here. So I think we all learned a lot about what it was like to live in residential care. And as Isobel said, in terms of the results, we do some really great things in residential care in British Columbia, but there's a lot more, and there is a lot more that we could do to do better. So a lot of people said it couldn't be done, and Isobel, I think it's a testament to your vision that we did do it, and the volunteers who contributed their time. So today's release is the next step in the OSA's long-term care survey, facilitating through you additional secondary analysis of the survey results. So thank you. So now I'm going to stop sharing my screen, if I can get up here. And I'm going to introduce Ben. So just give me 1 second. Hold on here. I can't even see. Okay, so you've got Ben's slide up there. Hold on, I gotta go. I gotta get out of this. Sorry, Ben, I'm gonna be there in a second. There we are. Okay, so Ben's now going to explore the metadata and the data structure with us. Benedito Chou is a senior analyst with the Office of Patient-Centered Measurement, and he leads the creation for us of the patient-centered measurement metadata for health ideas. Ben also designs and develops reporting and analytics solutions. He's passionate about data visualization, and you're going to see that momentarily, reproducible research, and visual storytelling. So I'm going to pass it over to Ben to explore the metadata for the Office of the Seniors Advocate Survey, provide an overview of metaspace and the Ministry's new Wiki, which is the Ministry's new Wiki, provide an overview of the Office of the Seniors Advocate's long-term care data structure, and provide us with a live demonstration and queries of the quantitative and the qualitative data for this survey. So Ben?
Thank you, Lena, and thank you, Lena and Isobel, for the great presentations, very informative on the visions and background and the process, the planning and the leadership that were in place that make the impossible possible. So in my sessions, I'm going to switch gear and focus on providing you an overview of the supporting documents that our office have developed to help you use the data, as well as an overview of the data structure, how the survey data are stored in health ideas, and then we'll end with going through some live example code in the SAE environment. So those are the topics I'm going to cover in my session. So we're going to go over the resources, going to introduce you to the new wiki developed by the ministry, which is called Metaspace. And then we're going to do a quick review of some of the support document that was developed. This include the toolkit, the cheat sheet, the technical reports, and a few other documents that help you use the data. Then we're going to dive into the data structure, showing you how the informations and the responses are stored in health ideas. This would be a review for some of you who have attended the previous user group, but there are some important difference here for this survey that I'm going to highlight in my sessions. And then we'll end with some example code in SQL. So just a quick recap on the resources that are available. We have Metaspace, which is the new wiki. In there, you'll find the data dictionary, some background information to help get you started, and a few example code snippets. And then on our office website, you can find a lot of supporting documents that we have developed. This includes the cheat sheet, the data user guide, the toolkit, the technical report, and then some supplementary document that we call the primer that covers some important methods that are germane to using survey data such as missing data, how to handle that, survey weighting. So give you some background information there. So it's kind of go from the most general overview to start with the cheat sheet, and then go in increasing details. If you want more details about the background of the survey and some of the methodology, then you dive into the technical report. So now I'm going to switch to my browser so I can show you the new wiki, which is called Metaspace. So I did log in the interest of time. So when you log in, you'll be greeted in this intro page. And then you'll see that there's different sections. The data holdings cover, all the different data access that health ideas have, including the patient sentiment measure data, the sector survey. And then they have an explanation of the different key concept indicator, and then various user guides for the different data access that help you use the data. And for our purpose, when you log in there, you can type search for PCM, and then it will give you the patient center measurements, lead you to that specific page. And then here you'll see just a quick overview page talking about what data is available at the moment, how to get started, the different data table and fields that you can query against. But the most important one that I want to draw your attention to is the data dictionary. If you click on that, you'll see, for those of you who have seen this, you'll be familiar. There's 4 tables or database view in Health Ideas that you'll be working with to pull data, including the OSA long-term residential care survey data. If you click Learn More, then this will bring up a searchable table. It takes a bit of time to load. But what's nice about this is compared to the old wiki is now you have a fully index and searchable table in terms of the 4 database view. So you can quickly, search for a particular type of columns you're looking for. I'm going to switch back to some of the bigger table ones. So for example, the respondent header table. So let's say you want to, see what information available in terms of concerning the date. If you do a quick search, it will then filter to just those columns that are of interest. And you'll find that, there's a different date information that captures, such as the survey date, the survey usage effective date, etc., and the discharge date. You can also look at sample values of those columns if you look towards the right for more information. So for example, if we click on the first one here, it will pop up another table that will show you some sample values from the database. So it gives you a really nice and quick overview and a feel of the data before you actually, set up your code for your own analysis. So it's a really good and nice tool to have when you're starting to explore the data. And then finally, there's a help section here. If you're new to Metaspace, you can go to here, and then they have instruction page here where they have some more videos, introductory video that you can watch to get oriented to how to navigate through Metaspace. I know they just did the schedule maintenance today, so the page look a little bit different right now. There used to be some video here, so they might be making some changes today. But the help page would be a good place to start if you're new to Metaspace. And then once you are familiar with how to use the site, then again, you can search for the PCM data by just typing that in the search bar. And then before I move off here, I just want to point out that from time to time, we will update the site with some attachments. So here you see that we have uploaded some of the support documents, such as the toolkit, to the page. One last important thing I want to mention is you can also subscribe to update. So I already subscribed to the PCM data holding. So that's why I say unsubscribe here. But if you want to receive email updates on a weekly digest as to what has been changes, then you can click on that subscribe button and then you'll be alert to any updated and changes to this page. So it's a great feature to have. Okay, so so this is the new, just a quick tour of the new wiki, the Health Idea Metaspace. I'm going to quickly switch to our office website just to show you where to find the other support documents. If you go to bcpcm.ca, then you see on the top banner, there's tools and resources. There's a page there. If you scroll down, you see the documents organized by the different categories that I described. Currently, the OSA document are not up yet, but we'll be uploading those to the website afterwards. So as you can see, those 4 documents are the main one, the main support document. And now I'm going to jump into those documents for the OSA survey and highlight some important information that will help you use your data. Okay, so I'll start with the cheat sheet, which is the most general of those 4 documents. In here, you find a quick summary of the survey tools, the questions that ask about the patient-reported experience, just a quick overview of the topics area that are covered. And then for this particular survey, we have the 3-hour-12 as the prompt. And you'll hear a lot more about that later on in the presenter sessions that are going to moderate by Rick. And then finally, just a quick summary of the survey plan that Lena gave an overview of. One point I want to mention here is that since this is a census approach, which means we try to interview every resident as well as a mass sample of the most frequent visitor, there isn't a survey weight developed to correct for any imbalance that were introduced by the sampling, because everyone was invited and participate. So unlike some of the earlier sector survey, like the emergency data and the acute IP one, there isn't a survey weight variable provided to you. That doesn't mean you're not encouraged to develop your own weight if you feel that that is important for your analysis. So that's always an option. But in terms of any adjustment that need to be made with the weight to correct for the sampling plan, there isn't one because again everyone was approached to be interviewed. Then the next document here is called Data User Guide. So this provides a bit more details than the cheat sheet, but have some of the same information. What is unique here is that it does have, at the end, it does have a background on the process to access the secure analysis environment. If you haven't been logging on to the SAE for a while and you need to be reminded of the steps, so you'll find those information here and link to additional resources on how to get access to the SAE and whatnot. And then next up in terms of the level of details, we have the toolkit. So the toolkits have different sessions. that cover the background of the survey methodology, which Lena had go over with you, as well as talk about the scoring, different response categories, and then response rate of the survey. One particular sessions I want to spend some time on that are unique to this survey is that there's some special code, which you'll see when we get to the live demo. Those are special numeric code that you'll see when you query the data. I'm going to zoom in on here. And they are here because if you remember, for the MFV survey, for the most frequent visitor, it's also a mail-in survey. And because of the nature of filling out the mail-in survey, and the survey have different skip logic, so certain questions are meant to be skipped, but sometimes respondent may not have read the instruction or followed the instruction, and they end up answering the questions. So what you see when you query the data, you actually see some funny looking values like 10,001, 9,912. So anytime you see a numeric response to the answer to that questions that have those values, refer to this table. Basically, if you see those very high number values, those mean those are questions that should have been skipped. But nonetheless, someone provided an answer to that anyway. So you still have the options to look at the response if you choose. But obviously, you have to do some manipulation with the data to make it usable. But in terms of how to decode that, this table will tell you what each of those values are. So for example, -8 is more than one response provided on single answer questions. And then you have those 4 digits or 5 digits values that are questions that should have been skipped. So you either subtract 1,000 from it to figure out what the actual response are. So for example, we'll take the 4-digit example here that start with a 9. You subtract 1,000 from it, then become 9,912, become -88. And then you can then look up in the data dictionary or the code book what's -88. It's actually encoding to find out what the actual response is. So we don't have a lot of the response, but just to keep in mind and don't be alarmed if you see that when you start querying the data. And then here again is a quick reminder of the 4 database field, which we'll go over when we get to the live code demo. And then to link those 4 database fields together, those are the key that you use. So survey definition and ID tell you which sector survey is in. And then you can use the attribute ID or attribute usage name to link the responses from the survey back with the respondent. And then there's also a unique identifier. There's an anonymized identifier if you only have level 2 access, where you don't see the PHN number. Then you use you can use the survey reps label to uniquely identify the person who completed the survey. Now I'm going to spend a bit of time here because for this survey, we actually have 2 anonymized identifier because we have a mass sample. So we have survey of the resident as well as responses from the most frequent visitor. So for the residents and the most frequent visitor, they will have a different survey response label because those are 2 different persons. There's also something called just a client label, which if you only have level 2 access, which you don't have the PHN number, and you want to match back the responses from the most frequent visitor to the same residence, they'll use the client label. And the client label will be the same for the residents and the match most frequent visitor. So there's two anonymized ID. So if you want to match the answer between the residents and the MFE, then you have to use the client label. If you're just querying them separately or just doing summary table separately between the two versions of the survey, then you can just use the survey response label. Okay, finally, we have the technical report, which is developed by NLC Health, and we provide some edits to it to help with clarity. And I can encourage you to read through those if you want to know more details about the survey. What I want to highlight to you are certain appendix on the technical report. So earlier you heard about the license and restrictions of use of the survey questions. So you'll find the text fragment in the appendix M and appendix N of the technical report. So if we jump to that here. So see in appendix M right now, you'll see the text fragment. So those are the approved text fragment that you can use when you're reporting result out. And you'll see that some, in addition to those inter-eye quality of life survey questions, there's those custom questions that were developed for the BC context. So there's also the text fragment for those. And they are grouped by the different theme or dimensions. And at the end, you can see the label for the 3 out of 12 for the prompts measure, which again, we'll hear more about later on in the later sessions. And then appendix N is where you see the same questions, but for the most frequent visitor. For the most part, they're pretty similar. So the label is just, so some of the questions, most of the questions you'll find is the same question in the resident survey, and then the same question asked from the most frequent visitor perspective, asking about the same topic. So then the next appendix I want to draw attention to is the codebook. Ooh, if I can type that right. So again, you have two codebooks, one for the resident survey, the other for the MFE survey. The questions are numbered in different sequence. So unfortunately, because there is some unique question in each. So question 1 in the resident survey is not the same as question 1 in the MFE survey. So when you do start to explore the data, you have to look at the codebook and take a look and make sure that you're actually querying the right questions. If you're interested in look at the same topic area. So the codebook is pretty standard. You know, tell you the numeric value and the label, whether multiple responses is allowed. And then it's also tell you whether that particular questions are used in the positive scoring. So percent positive scoring or top box scoring. Okay, so that's a quick overview of the background and supporting document. So now I'm going to switch gear to some live example code and to go over the data structures with you so you can start exploring the data. So I'm going to switch to the SAE now, which I have pre-logged in the interest of time. So my focus here would be on the prems questions. Unfortunately, we won't have time to really show you the response or query the problems we saw, but you'll hear a lot more about them in the later sessions. So this example code I'm going to show you right now will be put up into metaspace later on. So at the moment, it's not up there. They were having a schedule maintenance, so I didn't put it there in time. So you don't have to copy and paste anything. So just follow the example, and then I'll explain them as I go. Okay, so the first query is here is just to list the available survey concerning the long-term residential care. Now you see that there's actually two older entries here. Now not all of you may see that, but the first long-term residential care survey was actually done back in 2003. So that one is available in there as a legacy data. But what I'm going to focus on today are the last three you see in this table. So you see something called LTC, the survey definition ID FEMFIS_2. This contains the response to the most frequent visitor survey. And then you have another one called LTC res_2. So this contains the response to the resident survey. And then finally, you will notice there's an extra one, just called LTC_res_3. So this is a much smaller sub-sample where selections of residents were asked to complete two versions of the VR12. So that was done to validate the psychometric properties of the new VR12 that was adopted for the long-term care use. So this is smaller subsample on to validate this result later on in the later sessions. But for my sessions, we'll be focusing on mostly on LTC res_2. And then also with some example of LTC FEMFIS_2, just to give you a flavor of what the data looks like and have ideas for the residents and the MFV survey. So the first thing I usually like to do is to take a quick look at what the available survey questions. So if you run the next query, you'll see something similar to the code book that I showed you earlier, but now you're actually querying the data table here to find the information that you want. So while it's running, just a quick note. So survey definition ID, again, is will tell you which sector it's in. So you can easily adopt this query if you are pulling for emergency data. Just change that to ED_something else, and then you'll see the list of questions for the sector survey. And the database field we are pulling from is the res detail field, which actually has the responses. So once the result pool query result come up, you'll see those different columns. The one of most interest are probably called the attribute usage name. For the long-term care survey, the label you find here, the question number you find under attribute usage name is the same as the label you see in the code book. So if the code book say question 1 is the question for MFE can be alone when wish, then it's the same label in health ideas. So this would be the column you use to, if you want to pull out specific questions. And then the attribute label will give you those text fragments that I showed you earlier in the appendix as well. So if we scroll down a bit further, right now I grouped them by the 3 different surveys, so REST2, REST3, FAM phase 2. So you're seeing the MFE one right now. And you scroll down a little bit further, you start to see lots of comments column. So something unique about this sector survey is that at the end of each page, when the trained volunteer are interviewing the residents, or in the MFE survey, at the end of each sections, they are given the opportunity to provide additional comments just on that topic area or on that questions that was added in that page. So this is in addition to the overall kind of open-ended questions that we ask at the very end of the interview or the survey. So you see a lot more qualitative data for this particular survey because we have provided more opportunities for people to make comments. And I'll show you towards the end when we do some live example code on the qualitative comment, how to pull out those questions separately. And next, I'm going just to show you quickly how to query just the survey question to see where they are for the prompts question, the 3 out of 12. So if you just do a search and filter it to have attribute label with 3 out there, you'll see all the 12 questions in the 3 out of 12, and then as well as the label. And then for the underscore res 3 as a subsample, you'll see 2 sets of those. The one with the 3 out dash original are the original 3 out of 12 that have the default wordings. And then the one that just say VR are the adapted version that has been tweaked to use in long-term care setting. So, but you only see this VR original in the underscore, the rest underscore 3 sector survey. And then the next query I'm going to show you is to quickly check the valid response, because you see earlier that there are some non-valid response, such as those skip questions that shouldn't have been answered. You'll see a quick way to check inside the database is to run a query like this on the survey definition detail field table with the sector you're interested in. So when you do that, you want to look at the valid response column. So for example, here you can see on question 23, if you click on it, it will pop up this little window that will show you what are the valid response, so, and which of those response options are considered positive response. So in this case, 4, most of the time is considered positive response, as well as always. And then always are considered the top box or the top positive response, as well as other non-valid response codes. So for example, -88 is don't know, -87 in reviews, and -86 is no response. So for this sector survey, anything that is below 0 in the negative range, non-valid response, I don't know, reviews, and no response. And then if it's have those 4 digits and 5 digits code that I was telling you about earlier, those are also I guess they're not really non-valid response. They just response that probably shouldn't been there. But nonetheless, there was an answer for it. So. Okay, then the next query will show you how to do a quick count of the people that have answered at least one survey questions. So the respondent count, some of you might recall that has as a dummy indicator, it will have a value of 1 if someone have answered at least one questions. So if you sum that up, it will tell you the number of records that will have, or number of person that will have some survey answers that you can work with. Except there's for the resident survey, this is not completely accurate. And that's one of the reasons why I'm showing you this. You'll recall that there's only about 10,000 Western survey that was completed. But here instead you see almost 25,000. And the reason this in here is not accurate is because question 1 in the resident survey, which is the next query I'll show you, is the participation status questions that the training interviewer actually filled in to indicate whether the survey was completed, whether someone refused to answer the questions, there's a language barrier, or they couldn't finish the survey for other reasons. So to get an actual count of the number of completed resident survey, you'll need to query question 1, which will give you this participation status table. And here you see that if they have a code of 1 participate in the survey interview, that means they have completed a survey, and those residents would have some answer to the survey questions. We also have another group of people that started the survey, but they were unable to answer the questions, and the interviewer kind of determined they could not proceed further. So you'll see some partial response in another subgroup. But for the most part, if you want to focus on just the people that have, the residents that have completed the survey, then you would limit and filter your query to just those that have a participation status of 1. And the next query is just to break it down by health authority. I'm not going to run that. And now I'm going to run this one just to show you those skip questions that got an answer to it. So we're excluding comments from here, and then just look at any response value that are less than 0 or greater than 100. That will pull up those. You'll see that it's happened in quite a few questions. Most of them are those don't know or no response. Towards the end, you'll start seeing some of those 5-digit ones. So for example, here you see they're pretty spread out and pretty sporadic. So you probably will encounter them when you start exploring the data, because there's really no kind of, it's not specific to any one questions. It's just the nature of a mail-in survey. It happened usually with the MFE survey because it has a mail-in options. And then finally, you see more of those 9911. Okay, so moving on now to look at just a quick, just a simple query of the survey respondent header table. So just a refresher, the header table has person level information, so it doesn't have the actual answer to the questions. But in here, you'll find columns or information such as, which health authority the residents, the facility the residents are in or from, the admission day, the client label. So that's the unique anonymized identifier at level 2. Instead of the PHN, that's the ID you want to use to uniquely identify the residents. And then some demographic information, the gender. In level 2, you'll see the birth month instead of the birthday. There's also the facility name, facility label, facility code. Some peer group type information you'll find in the header table as well, such as the size of the facility based on the number of beds. And then language code, as well as the unit name if the facility have different unit. So again, those are either metadata or information at the person level or the facility level. Notice there's no weight variable, so you won't see anything in the normal weight column or expansion weight column. And then the respondent count is again a dummy indicator. It will have a 1 if someone have at least one answer to it. Respond count is a tally of the number of questions that resident or MFE have answered. So if say 94, that means there's 94 answers that you can use for that person. And we get to the survey detail field, which is the table that stores the actual response to the survey. And it's a really long table. So each row is an answer to a particular question for a particular person. So just to keep that in mind. So there's different column here. Again, the one of interest would be the label, which gives you the text fragment. The attribute usage name, which corresponds to the question number in the code book. Then under response value, this is where you find the actual answer to that questions. And it's encoded in the numeric code. And then the response label would have the corresponding label for that numeric code, if there's a label. Where there's a text response, so this is one way you can use, one column you can use to pull out those open-ended or qualitative questions. If it has a yes, most of them would be those open-ended questions. If it's a no, that means it's those Likert scale questions that are more common in the survey. And then if it's an open-ended comment type questions, the actual comments will actually be stored in a column called response text value. You won't see it when you query it. It will just say CROB, but if you click on it, then it will show you the text. And later on, I'll show you a way to quickly just scan what that string is to convert into string so you can see it rather than have to click through it every time. And then finally, two indicator column. One is positive, tell you whether the response is options is considered positive response. And then its top positive response tell you whether it's considered a top box response. And then similar things, if you query the MFE survey, SAM structure, SAM setup. So once you know kind of the structure of the respondent detail field table, you should know your way around because they have the SAM column, the SAM structure. The things that will differ are the different survey definition ID you use to pull out the sector survey. And if you have a specific questions you want to pull out, then you add that to your aware conditions, which is the next example, which just to show you how to quickly do a frequency table. Looking at question 2 for the resident survey, that can be a long questions. So while it's loading, as you can see, most of the actions happen in the where clause. So we identify the sector in here, then the questions using attribute uses name. And I usually like to, when I calculate percentage, I usually like to look at the valid percent, so exclude the don't know, no response. And one way of excluding those is use the is positive column. If it has a yes or no, then it's part of the valid response option. So doing that will then exclude those don't know and no response and other non-valid options when you query the data. Okay, so I'm going to bring this up. So if you run the query, you see a simple table like this that gives you the count of the number of residents that answer never, rarely, sometime, most of the time, always, and then you have a percentage, and also show you which of those response options are positive or top box score. And then the next one is just run the same questions for the MFE. But notice here now that a long questions is actually question 1 because the MFE doesn't have that participation status questions in the beginning. So the numbering got bumped up, I guess. So you have to be mindful if you're doing a side-by-side look at the resident response to the SAM questions versus the MFE perspective, just to make sure always keep the code book and make sure you have the right question number when you query the data. So some of the query does take a while to run. So actually, yeah, there you go. So you see the same table for the same question, except this time is for response from the MFE rather than the residents. Okay, so this concluded the example of just showing you some different way to query the quantitative data and the data structure. I think I'll pause here before you go into the open-ended comment, just in case people have some questions.
If you have any questions, please feel free to unmute yourself to ask your question or use the chat.
Okay, I'm just checking the chat box. I haven't been looking at the chat box. Was there any questions in the chat box earlier on?
I haven't seen any as of yet, but maybe we'll give it a minute or so to see if anybody has any questions.
Good to carry on.
Yeah, okay, perfect. I think we'll, oh, I see there's actually a question here. If,
okay,
yes.
let's see.
So, in the chat box is from Soko, and this individual asked, how did you populate the tables from survey results?
How do you populate a table from survey results? Can you elaborate on what you're asking? Are you asking how this query I just showed you work, or are you asking how the survey result got entered into the database in the first place?
And Soko, you can also unmute yourself if you'd like to ask your question using the microphone as well.
Oh, hi.
Hi.
Yeah, go ahead.
Because the survey was done by volunteers, and then so the result came in like I assume the survey was like paper-based, or the frequent visitors were like paper or online. That's my understanding.
Mm-hmm.
But residents surveys were done on a paper base. Is that correct, or?
Yes, that's correct. Yeah.
So how that the survey result ended up in the database? Like it was someone was collecting the result and entering to like Excel sheet or something, then import it to the database, or?
Shoko, we worked with a data collection vendor, and so all of the paper-based resident survey forms and the paper-based most frequent visitor forms or the online results were uploaded to the data collection vendor's system. And then we have a contractual relationship that requires them to transmit the data and to develop a survey file layout that meets the requirements for the ministry's Health Ideas Central Data Warehouse.
Okay, so it's sort of like outsourced that part of the process. So someone else did it for you?
We contracted with a data collection vendor that became a service provider to the 5 health authorities that operate care homes or contract care homes in British Columbia.
Okay. Okay. I understand. Thank you very much.
Okay.
Okay, yeah, thanks for your questions. Yeah, so, and just to add to that, so once the vendor collated those responses, before I get into Health Ideas, we have a standard protocol and procedure in place to do some check on this as well. So, so there's a lot of process involved actually in terms of getting the data ready in this form, because again, we have more than one sector survey, but we only have those 4 tables. So to make it work for all sector survey, this is the structure that that the architect of the database come up with that seems to be working well so far for us.
Yeah.
Okay, so I'm going to move on to the last few live demo code. I'm going to spend a bit more time on a qualitative comment compared to the last 2 sectors, because as I was mentioning earlier, there's actually more comments for the residents for this particular sector survey than the other sector survey, because they were given more opportunities. So there's a lot of rich information here that is available for you to explore and use if you're interested in, you know, the patient voices. You know, those comments might be a good place to start when you explore the data. So to start off, to pull out just the questions, just to see how many of those available that open-ended in nature, you can use this query. Basically, we're looking for anything that is a text response equal yes, as well as something that has common in the attribute usage alternative name. So sometimes you do have to use the attribute usage alternative name to isolate the questions you want, because the usage name is just a number. It doesn't tell you whether the type of question it is. So this is that one instance where that come in handy. So if you run that, you'll see quite a few questions. Against those loosely grouped by the topic area, because the questions when they do the interview or for the MFE, when they fill out the paper or online version, there was similar questions. Questions about food are all presented in the same page, so to speak. So you'll see for each of those sections at the end, they were given the opportunity to provide comments. So if you want to look at comments specific to the sections, you'll have to find out the question number from here, right? So if I'm interested in comments concerning the privacy question sections, then you pull out responses from questions 4. And then if it's food, then question 8 and question 13. Some of them you see 2 comments because that sections go into the second page. So again, at the end of each kind of sections or page, respondent, residents, or MFE were given the opportunity to provide comments. So that's why you see a lot of those. And each of those comments are also coded to provide themes as well as variants on whether the comments is positive, negative, or both. So this kind of gives you some quick context when you're exploring those data. So if you want to only look for comments that has been flagged as a positive comment, you can do that, by using, the valence column or the valence informations in this table. And I'll show you some examples shortly. But the first one is just a very simple query to show you whether there's actually a comment. So not everyone would have some kind of comment. So Q105 is actually the last questions to ask whether if they have anything to add. So this is the typical general open-ended questions we ask in the end. And you can see that you have about 4,300 comments that you can work with for the resident survey. So there's a lot of comment there. And some of them are quite long. And to see the actual comment, you can then just run the next query. So earlier I mentioned if you just query the response text value, you just see this CLOB, and then you have to click on it to actually see the full comments. So this query, I add a little bit of conversion here to convert that type of data back into just a normal string. So you can set it how many characters you want. I just set it to 100 at the moment. It seems to work fine. So then you have this additional column that you can quickly just scan through and take a quick look at what people are saying. And then the next query will show you how to do a quick count of the valence of the comments. So how many of those comments are positive, negative, neutral, or both. So this is just on the last open-ended questions. And you can always just change that to a different question to see the valence code for that particular comment for that topic. So now that you know how to pool the comments, you can start, doing more complex query when you say, okay, I only want to look at comment that has been coded with the theme with spec. So this is the query that you will use. Okay, so this one I didn't do the conversion. So you only see this here, but as you can see in the theme, it's pull out only the comments that has been coded with the theme with spec. So if you have a particular theme in mind and you just want to browse through those comments, you can do that. And then we run that with more. Okay, so that's actually the last one I have for the qualitative comments. So I'll pause one again for questions. And if we have time, I'll show one more query. So.
And once again, you could ask your question using either the chat or muting yourself. And I'm going to unmute those of us who are calling in as well, just in case it's for you to unmute yourself. So please feel free to ask your question using the chat or using your microphone.
I think I saw one question about from Yishan, asking, is there any potential privacy concern with the open text comment in secondary use of data? Yeah, so I see Lena will respond. So I probably should have started with that. So the comments, before they get sent back to us as well as our ideas, they were masked with any personal identifying information. So you'll see some XXXX or some other masking mark in there instead of whatever that personal identifier is.
And if we have any more questions, feel free to unmute yourself or use the chat function as well.
Hi, this is Yingshan again. I'm curious what information on the facilities are collected.
Okay, good question. So I'll go back to one of the earlier query. So there's some information such as the size of the facilities, like based on the number of beds that I think I showed you earlier. I mean, there's also some other information, but not too much. Let me find that. Where is it?
And it includes information about the health authority, where the facility is located, as well as are they organized then into peer groups based on bed size? Bed number?
Yeah, there is one right here. This one here. Oh, so I just went through it. Yeah, this one here. Yeah.
I see. So it's more very high level information on the facilities. So is any potential for linkage to facility if someone wants to have a little bit more detailed information on the facilities?
Can you give us examples of what you would be looking for?
Well, I'm not really in this research area, but if just a researcher, maybe they are more interested in certain attributes of a facility than linked to the satisfaction of the residents. Is there any potential to do that?
Yeah, there is. We were talking about that a couple of days ago. What you can do is you can link to, there's facility tables that are available in level 2. So it is possible and easy.
I see. So it's there is a separate table on the facilities, sounds like.
Yeah, you can link to the facilities table, like long-term care, and there's a bunch of tables in level 2 that give some data on the facilities, like there's CHSA, where they're located, size, all that kind of stuff. So you can get access to that if you have level 2. So if you have access to the survey data, then by default, in terms of level 2, if you have access in level 2, you would have access to the surveys, and you would have also access to the other data sets that are anonymized.
I see. So what is the linkage key for that link?
Let me see here.
Yeah, I think there's a facility ID number that is standards across those different data access. Now,
I'm just going to send the code here. I've got the code written. Tim Jeff gave us it the other day, and I was just going to here. I'll send it to you. Oh, undo.
I wonder if in addition, maybe we could ask Rob Cowan-Douglas about his thoughts around using the Office of the Seniors Advocate's Quick Facts directory to understand the characteristics of the different care homes, because that would include whether they're private, for-profit, not-for-profit, health authority owned and operated, what the staffing hours are, the average staffing hours.
Oh, definitely. Yeah, this is Rob here,
yeah.
And in my presentation later, I'll touch a bit on the Quick Facts directory and linking it into survey data. I'm not going to get into the variables you link on or anything. I do it at a more high level, but within the PCM data, I did a fair amount of cleanup with Claude Tucker from Resonate. We cleaned up the facility names, the facility labels, and the facility identifiers to hopefully permit clean linkage to the delivery site registry, which is now in the CC site table. I don't know the full AHIP table name that would be in metaspace, and also into Quick Facts. We use the Quick Facts facility names, so you should be able to match on the name. There's also within Quick Facts the 5-digit CAI indicator, which is actually the ministry facility ID translated to base 20 with a 9 stuck in the front. Do not even ask me who came up with that, but anyways, that's how it's done. All that said, there should be clean linkage with Quick Facts, which has, as Lena mentioned, has care hours. It has food costs, something else I'm going to touch on in my presentation. It has licensing infractions. It has accurate bed counts, more accurate than the ministry has, because we go straight to facilities and ask them. We also talk to health authorities and ask them. It has ownership. It has the operator, so you can identify chains. For example, this has been something that's been a topic lately in the media, particularly with COVID-19 outbreaks. So yeah, there's a whole lot of stuff there. I would encourage people to see if they can link into Quick Facts if they need some information that can't be found in Health Ideas. And also my understanding is a lot of people who get data out of Health Ideas are not directly accessing it. Instead, they get an extract. So if you have an extract, you probably can't go back and link to other things, but you can link on facility name, for example, because that's not being anonymized.
I see.
Excellent. Thanks, Rob. So for the people who may not be aware, if you go to the Office of the Seniors Advocate's website, you can look for the Quick Facts directory, and that's what Rob is referring to.
Let's see if I can pull that up. I think it's somewhere here.
Yeah, Google there.
Quick Facts. Yeah, there we go. Yeah.
And the results at a facility level are included there too. So click on the long-term care Quick Facts directory, and then you'll see when that comes up.
Yeah,
you can search by facility name, and then when you go to a specific facility, at the top there's a link to the survey results.
There you go.
Click here for residential care survey results, but then you've got all of these other indicators that the Seniors Advocates Office populates. Okay.
Yeah, thank you.
Good. Maybe what we could do, Ben, is we could put together a little summary of how to access this and some of the comments from Dave and Rob, and send that out to people who've participated on this call, and also post it on the different websites.
Yeah, that's a great suggestion. Yeah. Thanks for the questions, and thanks Dave and Rob for your comments. And and Rob did a lot of great work helping us to fine-tune those facility labels. There's still some work we're doing behind the scene to make that label more useful for the linkage. So, but we're not at that stage yet. So, but Rob did a lot, was a big help in that process. So thank you for that.
Yeah, thank you. Okay, so hearing no other questions from Ben, for Ben, I'm going to say thank you, Ben, and move us along to showcasing 4 examples of analyses that have been conducted to date using the OSA survey results. And I'm grateful to Rick Sawatzky for offering to facilitate this session. And I'm grateful to our 4 presenters who Rick will introduce. So I'm just going to let you know a little bit about Rick's background. To those of you who've been involved on our BC Patient-Centered Measurement Steering Committee or any of our other work, Rick is no stranger. He's a friend to the Provincial Steering Committee and to the Office of Patient-Centered Measurement. So Rick comes with a really interesting background. So he sees his work in the area of measurement through the lens of a registered nurse. He's also a researcher and an educator who has a full professor role at Trinity Western University. And Rick has been motivated by a desire to reorient or refocus a system of healthcare or healthcare delivery that's system-driven and what works really for the majority of people to a more person-centered healthcare delivery mechanism that really pays attention to those whose needs are not being met. So you'll see a lot of Rick's work is often looking at frail older adults, which makes him perfect for today's session. So as I mentioned, Rick is a professor of nursing at Trinity Western. He also holds the Canada Research Chair in Person-Centered Outcomes. He's the lead of Patient-Centered Measurement Cluster with the BC Support Unit. And he's the head of the Patient-Reported Outcomes Program at the Centre for Health Evaluation and Outcome Sciences, which is based at Providence Healthcare. So I think that, you know, Rick is just the perfect person to facilitating the presentations that follow that are going to show you examples of analyses that have been done using the OSA survey result data. So Rick, I'm going to pass it on to you.
Sure, thanks very much, Lena. I'm going to share my screen here. There we go. So thanks very much. It's really been a great pleasure to collaborate with the Office of Patient-Centered Measurement and to work closely with Lena and others on this important survey initiative. Bringing attention or giving voice to people in long-term residential care and their families. We have worked hard to ensure that the survey provides valuable and comprehensive information on people's experience, as we've learned so far. And to this end, we have included questionnaires that have a strong and scientific really rigorous history of development and use. So we've already learned that a large part of the survey focuses on asking questions about how is your care, you're being the residents in long-term residential care. And for this purpose, we've already talked about that. We've included an established experience questionnaire called the INTRI Residence Quality of Life Survey, with the addition of custom questions of particular relevance to BC. However, knowing about people's experience of care is not enough. In addition to measuring experiences, we've learned that it's also important to find out how people are doing in terms of their health. Typically, health measurements are based on clinical indicators of disease progression. However, these indicators do not necessarily correspond with how residents view their own health. Therefore, we've included more questions of also focusing on how you are doing. So not just how is your care, but also how are you doing, with the goal of measuring residents and family caregivers' views of their own health, including their physical functioning, their social function, their symptoms, and aspects of psychological and emotional well-being. And we've already referred to the use of the Veterans RAN 12-item short form questionnaire, which is a version of the SF family of instruments, very widely used and well-established questionnaire for measuring physical and mental health outcomes. We've adapted this for residential care. So together, answering questions about how is your care and how are you doing provide important questions about what matters to you, both residents and families. And these questions provide a foundation of what we call a quality of life assessment, widely referred to as quality of life assessments, measuring what matters to individuals about their quality of life, healthcare experiences, and physical and mental and social health. And so I just wanted to take the opportunity to share resources that we have developed together with the Office of Patient-Centered Measurement and many other stakeholders about quality of life assessments that are available online at healthyqualityoflife.com. These resources target these different audiences, including older adults and family caregivers, healthcare providers, managers and leaders, and government leaders and decision makers. So there's resources for each of these audiences, including videos and infographics. So with this background in mind, I'm very pleased to introduce to you a couple of exemplars of research using OSA survey data, focusing on what matters to long-term care residents and their families. The first study that we're going to learn about addresses the question of how do residents view their physical and mental health. We sought to address this question by working with a postdoctoral fellow, Rozanne Wilson, funded by the Canadian Frailty Network at Trinity Western University and the Office of Patient-Centered Measurement, to adapt an existing health-related quality of life measure for use in residential care. So Rozanne will present first. The second question, which we often encounter, is about whether residents with different levels of cognitive functioning provide valid responses to survey questions. We already heard Isobel commenting on this and mentioning that often residents are not consulted about how they experience their care and their health outcomes. And this is exactly why the survey took place. Dr. Lara Russell will be reporting briefly on analyses we conducted to address this question, specifically with respect to the measurement of physical and mental health of residents. And the third question pertains to how residents' experiences with care relate to their perceived physical and mental health outcomes. And we supported Mary DeLong in her work on a master's thesis in nursing at Trinity Western University School of Nursing to specifically address this question with respect to the importance of relational aspects of care. And the fourth question pertains to linkage of OSA survey data with health administrative data. And this question will be addressed in a presentation by Robert Cowan-Douglas from the British Columbia Office of the Seniors Advocate. So without further ado, I'm going to turn now over, that's all I'm going to say, and I'm going to turn it over to our first presentation by Rozanne Wilson. And just a note to our presenters that we have to keep this very brief. We are a little bit behind on schedule. So Rozanne's research is focused on developing and evaluating tools that promote social participation and person-centered care among older adults. She has experience conducting research with residents in long-term residential care settings and with the development and evaluation of patient-reported outcome measures. So I'm going to turn it over to you, Rozanne, if you could share your screen.
Great, thank you, Rick. Thank you for the introduction, and thank you everyone for the opportunity to present our findings. And I'm just going to share my screen now. And everyone can see that okay?
Yep.
Okay, perfect. Well, as Rick mentioned, I'm here to present our findings on measuring health status in long-term care residents and adapting the veteran-ran 12-item health survey. So the big question here that we're interested in is, how do residents perceive their physical and mental health? And to approach answering this question, we used patient-reported outcome measures. So we turned our attention to PROMs, as they're useful tools that measure a person's health status directly from the person without interpretation from a clinician or anyone else. So PROMs are used to measure a patient's perceived symptoms, such as pain or fatigue, function, including physical and social function, as well as feelings, such as mood and emotion. So prior to the 2016 OSA Residential Care Survey, no PROM had been specifically developed to measure physical and mental health status among adults living in long-term residential care homes. So that led us to look at what PROM would be appropriate for the context of long-term care. And of interest was the veteran-ran 12-item health survey, or the VR12. It's a generic or general PROM that measures perceived health status among adults, so both physical and mental health domains. The VR12 includes 12 questions that measure 8 domains of health status, including general health, physical functioning, role physical functioning, bodily pain, role emotional, vitality, mental health, and social functioning. And there are 2 additional items included in the questionnaire that ask the person to reflect back over the past 2 years. There are 2 recall periods available for this tool, the past 4 weeks or the acute period, which is over the past week. And there are various response scales included in this measure. But despite the widespread use of the VR12, its validity and use among residents living in long-term residential care had not been evaluated. So this really led into our project, which was looking at the development and validation of the adapted VR12 for long-term residential care. And this was done to support the OSA's survey. So to give you a broader context of this study, that I'm talking about today, it was a phase 1 of a larger 2-phase validation study. So I'll just be focusing on the phase 1 today, which looked at the content validity of the VR12, and then using that information, informing the development of an adapted version of the VR12 that was acceptable and relevant for people living in long-term care. And the adapted version was termed the VR12 Long-Term Residential Care Canada. So the VR12 LTRC-C, I'm just going to call it the adapted version throughout the presentation. And the next phase involved the initial psychometric evaluation of the adapted measure that was used in this, the survey data that we got back. Oops, sorry about that. In terms of study objectives, we really wanted to evaluate the content validity of the VR12, so item acceptability, relevance, as well as comprehension. And then based on those findings, inform the development of adapted version of the VR12 that was suitable for the long-term residential care setting. This study involves several steps. So the first step, we obtained initial feedback from long-term care residents on the VR12. So this was kind of preliminary feedback about the tool. And then the research team came together and discussed the findings from that, as well as the face validity of the VR12 items. And based on those discussions and those findings, we moved on to conducting cognitive interviews with a larger sample of residents living in long-term care, residential care. And then we again convened and had a research team discussion and consensus to finalize the adapted VR12 items. In terms of the cognitive interviews, we had a sample of 18 older adults from a single long-term residential care home. The majority of the participants were male and had little to no cognitive impairment, which was assessed using the Cognitive Performance Scale, or the CPS. In terms of the CI results, the majority of residents indicated that the VR12 was easy to understand and that the original physical function items included in the VR12 had activities that were not relevant or appropriate for this population or setting. For example, climbing several flights of stairs doesn't happen typically in the long-term residential home setting. So based on the results of the interviews, a few modifications were made to the VR12. So the 2 physical functioning items were replaced with 2 items from the VR36. The context was repeated for each item and the recall period was added to each item. And the word work was removed from instructions and items that included that word. And we also added instructions for some of the domains. And I've just highlighted an example here of the 2 physical functioning items that we actually replaced. The original item says moderate activities such as moving a table, pushing a vacuum cleaner, bowling, or playing golf. Well, most of the residents indicated that this is not relevant or appropriate for them in the context where they live. And that item was replaced with, does your health now limit you in moderate activities such as walking a block? And the second physical functioning item was talking about climbing several flights of stairs. And again, this was deemed not appropriate or relevant to residents in this setting. And so we used an alternative item, does your health now limit you in bathing and dressing yourself? To wrap up the findings from this qualitative study, it shows that an existing PROM can be adapted for use in the long-term residential care setting to measure physical and mental health outcomes from the resident's point of view. The study also shows that CI, or cognitive interview methods, can be used in this setting, and that evaluating content validity is the first step to improving item comprehension, relevance, and appropriateness in a widely used generic PROM. And the findings also provided evidence for the content validity of the adapted VR12. So establishing content validity in new populations is important for the ongoing validation of a PROM. And again, for psychometric evaluation of the adapted VR12 is underway. And here's just a highlight of a publication that reports more details on the qualitative evaluation of the VR12 if you're interested in learning more. And this is our opportunity here to thank all of the sponsors of this project, the Office of the Seniors Advocate, the Canadian Frailty Network, as well as CIHR, all contributed to this project. And if you have any questions, please feel free to contact myself or Dr. Sawatzky. And that's all I got.
Perfect. Thanks so much, Rozanne. Right on the 10-minute dot. I think, well, maybe we could open for one question. We do have our contact information, so we might have to do, if there are extensive questions, do that via email more so. But if there's a burning question, happy to entertain that, and otherwise we'll move along. Any questions for Rozanne? Great. It's always difficult via webinar. I'm not seeing the whether any questions are coming up. So, Belinda, are we good to move along? Or?
I don't see any questions yet. Yeah.
Yeah.
Okay,
Okay.
that's great. Yeah. If anyone has any questions, yeah, just like Rick said, feel free to reach out or read our paper.
Thank you, Rozanne. That was wonderful.
Thank you.
Summary.
Yeah.
Okay,
really
great.
good.
Thank you, everybody.
Thanks so much. Okay. Well, then we'll move on to our next presentation by Dr. Lara Russell. And it focuses on whether people in residential care can provide valid responses even at different levels, if they have different levels of cognitive functioning. And so Lara Russell is a research associate at Trinity Western University and at the Center for Health Evaluation and Outcome Sciences at Providence Healthcare, where she works with me on several projects involving PROMs and PREMs. And her research interests include the development, validation, and use of PROMs and PREMs in research and clinical context, and the use of web and mobile technologies for survey research. She obtained her PhD in measurement, evaluation, and research methodology from the University of British Columbia. So I'm going to turn it over to you, Lara, to share the results of these analyses. Thank you. If you could just share your screen.
Yes, thank you, Rick. So I'm going to share my screen. Okay, so that should be sharing my screen. And can everybody hear me? Those are my two questions before I start.
Yeah, both good.
Yes,
both good.
Yes, and
Great. Okay, so I just want to say thank you very much to Lena and Rick for the opportunity to share this research, which I think fits so well with the philosophy behind the survey that Ms. Mackenzie described so eloquently at a few hours ago. It's just, I think these are some really interesting and exciting analyses that we did and really valuable findings, I think. So I'm thrilled that we can share, and thank you to everyone for being here to listen. I'm just going to jump right into this because I know time is short. So we've already had a little bit of an introduction to PROMs. Thank you, Rozanne. That saves me some time. So PROMs can engage people in assessments of their own health and well-being, which is a great goal to have. But as we've heard, the fact that some long-term care residents may experience cognitive impairment has led to concerns about using self-report measures in this population. And this is a legitimate and important question. And in fact, there's a whole area of PROM development and validation that's concerned with the whole issue of whether measures like PROMs work equally well for all respondents. And when they don't function the same way for everyone, we have what we call differential item functioning, or I'm just going to say DIF for short. And so the goal of the study was basically to determine if cognitive functioning leads to DIF on the adapted version of the VR12. Just a really quick little bit of background here. In health, we're often interested in measuring things like pain, depression, quality of life, happiness, even physical functioning. The challenge is that although we know that these things exist, so that's the blue bar at the bottom of the screen, we know they're there. We can't observe something like depression or quality of life directly. So we use a PROM and ask people to tell us about these things. The answers to the PROM questions provide information about whatever it is we actually want to measure. So an example would be physical health. we can't taste it, we can't see it, we can't hear it, so we can't measure it directly. Instead, we ask people about their health, that's the green bar at the top, and from that, the answers to those questions, we infer something about the thing we want to measure, the blue bar at the bottom. When we do this, when we use prompts, we assume that the scores, the answers that we get, that these scores reflect respondents' perception of the construct we want to measure. For example, if we ask someone to rate their health, we assume that their answer is driven by how they perceive their health to be, and not by other things. But we actually know from previous research that this isn't always the case, and that people interpret and respond to questions in ways that are also influenced by demographic differences, cultural differences, different experiences, personality, and yes, potentially cognitive functioning. And when this happens, the reality is that the answers to the questions reflect the construct plus something else. That something else being these other things that were not intended and are not visible in the score. And this is what we call differential item functioning. So here's a sort of an illustration of how this may play out in the actual scores that we see. Let's say that we want to measure physical health, and we have two groups of respondents. One group has less cognitive impairment, one group has more cognitive impairment. And both of these groups have the same level, true level of physical health. Of course, we can't know this because this is the unknowable thing we can't measure directly, but for the sake of this example, the situation down there in blue is what we actually hope to measure with our prompt. And if there's no diff, both groups are going to give us the same answer to the prompt question, and that answer will reflect reality. But maybe if there is differential item functioning for this question, we may end up with a scenario that looks more like this, where one group provides an answer that doesn't match up with reality for reasons that don't have to do with the thing we're trying to measure. And we end up with a score that's biased for people with more cognitive impairment. It overestimates the level of physical health. And, excuse me, when this happens, of course, it makes it difficult for healthcare providers, decision makers, researchers, anybody, to interpret the meaning of the scores correctly. So that was just a quick introduction to the topic of diff, which I'm sure you can imagine is huge and much more than this, but hopefully this gives you the idea. Now I'll move on to the study itself, which, as I said, was looking at whether cognitive functioning leads to diff or questions on the adapted version of the VR12. So you've already heard quite a bit about the sample, about the survey, about the measures, so just a very quick recap here. We used the adapted version of the VR12 that Rozanne just described. The sample that we used was just under 8,000 people who took part, so residents, not family members, residents who took part in the OSA survey. Cognitive functioning was assessed via the CPS, the Cognitive Performance Scale, and we grouped people into 4 cognitive functioning groups. I've put the percentages there so you can see sort of how it was distributed. About 80% had mild, moderate cognitive impairment, according to this. There were a lot of different ways that you can investigate diff. We used something called the logistic regression approach. This tests for diff for each individual question relative to the thing that you want to measure. So, for example, physical or mental health, in our case. And for each question, you have 3 sequential models, and you evaluate these models relative to the diff detection criteria that are up there in the top corner. In the first model, you're basically quantifying the relationship between the question and what it is you want to measure. So for example, physical health, you're quantifying that relationship before introducing the potential source of diff. So this is your baseline no diff model. Then in the second model, you add to the model the suspected source of diff. In this case, a grouping variable that represented the 4 levels of cognitive functioning. And then what you do is you compare your model 2 to your model 1. And if in making those comparisons, you meet the criteria for diff, you have something that we call uniform diff, which simply means that the direction of the bias is consistent across all true levels of the construct. So physical health is always overestimated with people with for people with more cognitive impairment. So now that you've established whether there's uniform diff or not, you add another variable to your model, and this is a test for something that we call non-uniform diff, which is a little more complicated to wrap your head around, but basically an example would be for people who have more cognitive impairment, the PROM question overestimates physical health at lower levels of true health, but underestimates it at higher levels of true health. Yeah. And that was, again, sort of a quick introduction to the methods. And now I'm going to go on to the results, which were actually really quite straightforward and we found really encouraging. So here first are the results for when we're looking at the questions that measure physical health. The bars show the strength of the relationship between the question and the thing that we're trying to measure, in this case, physical health. The green part of the bar is the percentage of that relationship that is not affected by diff. So if you think back to the previous slide, the green bar is that model 1 baseline no diff model. And the little bit in sort of a nice burnt orange color, that's the part of that relationship for each question that's affected by diff. And what I did in this case was I just smushed the uniform and non-uniform diff together, in large part because, as you can see, those orange pieces are tiny. And in fact, when we evaluated them sort of against the diff detection criteria, none of these met the criteria for diff. So essentially, no diff when measuring physical health. We switched to mental health. We did all the analyses over again, 3 models for each question. And once again, we can see that those orange pieces of the bar are tiny and none of the questions met the criteria for diff. And then just to do a little extra check and be 100% sure, we actually repeated all of these analyses, but we contrasted just the no impairment group and the severe impairment group based on those CPS grouping scores. Just to be able to really pull apart where we would be most likely to see an impact. But once again, none of the analyses met the criteria for diff. So basically, what that tells us is that residents were responding consistently to the questions, regardless of their level of cognitive functioning. The answers were not subject to diff and were giving us unbiased self-reports of physical and mental health status, which supports the use of this PROM in this context. And I think that is all I had to say.
Yeah, that's great, Lara. It's really groundbreaking work, actually. Like Isobel mentioned, there aren't many surveys conducted of residents' experiences, and it's partly because of this perhaps misbelief that residents can't respond in valid ways to these questions, and that's what this study addresses. So it's great. I think we actually need to move on. So maybe we'll have a few minutes after the presentations for questions and answers, but I don't want to cut the other presenters short. So if okay with you, Lara, I think we'll first move on. And of course, people could always contact us as well.
Absolutely. I want to hear the other speakers too, so.
Yeah, great. Thanks so much. So then I'll move on to the next presenter, who is Mary DeLong, and she's going to talk about the relationships between experiences and health outcomes as perceived by residents. She is an RN who has worked at the bedside in nursing management, and for the last 8 years has been a nurse educator with Bow Valley College in Calgary. And she recently completed her Master's of Science in Nursing at Trinity Western University under my supervision. And she is passionate about person-centered care and hopes to empower both providers and stakeholders to fully embrace and operationalize a person-centered approach. So I'm going to turn it over to you, Mary, to share your thesis work.
Thank you so much, Rick.
Share
my screen first here, and Are you able to see that, Rick?
Yeah, perfectly. Yeah, and we hear you well.
Okay. So this study focused on the associations between relational aspects of care and self-reported health status of residents living in long-term residential care homes. Background information that is pertinent to this study includes the concept of person-centered care, which has been identified as a goal in many long-term care facilities. Person-centered care acknowledges the person behind the patient, and it also recognizes personhood. Person-centered care essentially affirms the worth of an individual or resident and places an emphasis on obtaining the resident's point of view. Relational aspects of care, on the other hand, are considered to be foundational to person-centered care. These are related to the interpersonal interactions between a healthcare provider and a resident. And these can be viewed as distinct from instrumental aspects of care, which tend to be more task-focused. Relational aspects of care involve authenticity, human connection and relatedness, compassion and empathy, dignity and respect, having knowledge of the resident, and also having a desire to allow the resident's preferences to guide choices. The study began with a thorough literature review. There were few studies located that focused specifically on relational aspects of care. The literature supported that staff-resident interactions can impact the sense of personhood, the sense of meaning, and the overall well-being of residents. The literature review really brought out that those things that seem to matter the most to residents are dignity, respect, autonomy, personal choice, connectedness, and relationships. The research question that this study addressed was, to what extent do relational aspects of care explain variation in self-reported mental and physical health of residents living in long-term residential care? The methods included an analysis of a subsample from the BC Residential Care Survey from 60 facilities in Providence Health and Vancouver Coastal Health Authorities. The survey questions could be grouped into two broad categories. There were the questions related to the residents' experiences of care, and these were obtained from the INTERRI Self-Reported Quality of Life Survey for long-term care facilities and the BC Custom questions. And the second category of questions involved the residents' perceptions of their physical and mental health. And these came from the Veterans RAN 12-item health survey, or the VR12. This slide depicts the experiences of care as predictors of health outcomes and really outlines how we set up the study. What you're seeing there on the left is the experiences of care and also how we measured them. If I can draw your attention to the summary scales that are shown here with the superscript 1. These were all based on the INTERRI survey questions and were developed as summary scales by Morris and his colleagues. What they did was they developed 5 summary scales that were related to resident perceptions of aspects of their life or aspects of their care. So at the top there, you can see in the shaded boxes, the caring staff scale and the staff responsiveness scales were both related to the care received. And those were both considered to be relational aspects of care for this study. We also, on the bottom, took the rest of those scales, which were related to the life experiences of the residents, and those were the food scale, the personal control scale, and the social life scale. And those were combined along with some individual BC custom questions to form all of the non-relational aspects of care questions. And so essentially, these were the variables in this study. The experiences of care all formed the explanatory variables for the study, whereas the health outcomes on the right formed the response variables. Where we got those measures was from the VR12 that you guys have heard about. So the self-reported physical health measure was the physical component score derived from the adapted VR12. And for mental health, it was the adapted VR12 questions related to the mental component score, or MCS. So for this study, we ran a regression, and we essentially used 2 individual regression analyses, one for PCS and one for MCS. The statistical methods that we used included descriptive analyses, multiple imputation to accommodate missing data, a sequential model building approach, excuse me, that involved bivariate analyses as well as hierarchical multivariable linear regression in order to select our variables. This was used to evaluate each variable's contribution, and it was done independently of all the other variables in each block. Finally, once we had our variables selected based on their statistical significance of the regression coefficients, we then conducted a hierarchical multivariable linear regression to answer the research question. That brings me to our study findings. From the descriptive statistics, you can see that the sample was 63% female. 50% of the sample were age 85 or older, with the mean age being 82. For marital status, 42% were widowed, and another almost 22% were married. Do keep in mind that we worked on a subsample of the overall survey, so our sample size was 2,108. Notice the average time in facility was an average of 3.28 years. This shows the results of the physical health regression model, and I'd like to point out here that there were 5 models in the regression. So for both PCS and MCS, we entered the demographics in as the first block to statistically control for any variation based on demographics. What you see in the percent change is the amount of variance in physical health that is attributable to that block, and it is controlled for all the other blocks. So you can see here that the percent change for the relational care summary scales was 6.6%, and the percent change for the relational care BC custom questions was 9.4%. So in total, these 2 blocks that were considered relational care made up 16% of the total variance in physical health. So you see at the bottom, the overall variance that is explained by the model was 27.9%, and that was including all 5 blocks. Likewise, for mental health, you can see that it included 6 models. It included the "do you want to live here" overarching question as block 6. This question was statistically significant for mental health, but it was not for physical health, and therefore it only made it into the mental health model. You can see that 11.5% of the variation is attributed to the relational care summary scales, and 8.1% of the variation is attributed to the relational care BC custom questions. Those together totaled 19.6% of all the variance in the explained by the model as being from relational care. The entire model here accounted for 27.4% of the variation in mental health, sorry. And what this slide shows is a Pratt index of relative variable importance. This was calculated as a complement to the regression, and what this does is it partitions out the variance for each variable. So of the total variance accounted for by the mental health model, the relational aspects accounted for 48.3% of that variance, and the non-relational aspects accounted for 45.3%, and demographics 4.1%, and then the overarching question, do you want to live here, was 3.4%. What you can see at a glance here is that the relational care did have more importance to mental health outcomes than it did to physical health outcomes. For physical health, you can see that the relational aspects made up 34.5% of the total explained variance, whereas the non-relational was 62.4%, and then the demographics 4%. And, you know, at first glance, it seems that perhaps this is not very much, or maybe not that significant, but these do both reflect a statistically significant moderate effect size in terms of results. And when you consider all of the things that contribute to someone's health, it actually is a fairly astounding number when it came out in the results. To conclude, this study has shown that relational care is positively associated with residents' self-reported physical and mental health. Limitations include the cross-sectional nature of the design, which naturally limits inferences about causality. And some final thoughts. Unless we build relationships with our residents and get to know what possibilities exist for them to live their fullest life, we will continue to provide the same institutional approach of the past. And I would like to acknowledge the Office of the Seniors Advocate of British Columbia for, you know, this massive and just brilliant undertaking. The BC Office of Patient-Centered Measurement for facilitating that survey, Trinity Western University, and also the Canada Research Chairs Program. And I would be remiss to not acknowledge all of the residents who took part and the family members. This study did not consider the family member survey, but for those people that actually took the time, you know, a 50% response rate, as Lena mentioned, is phenomenal. So thank you very much.
Great. Thanks very much, Rozanne. It's wonderful to see how you link your passion to numbers, analysis of numbers, and to see how the two can complement each other. I think we need to move on though. So I don't want to cut our last presenter short. So we'll see if there's some opportunity for questions after the next presenter, but we'll first move on. And of course, people can always contact the presenters if there's further discussion. So I'm going to now introduce Robert Cowan-Douglas, who is the Manager of Analytics for the BC Columbia Office of Seniors Advocate. Rob is a health economist by training and has overseen analytical reporting of the OSA since 2016. And Rob has extensive experience working with linked data sets in the Ministry of Health Central Data Warehouse, Health Ideas. So he's the perfect person to present on linkage opportunities using examples from the OSA data. So Rob, I'm going to turn it over to you. If you could please share your screen.
Thank you, Rick. Let me just get this going here. Just confirming people can see this.
Yes, perfect.
Okay,
and
excellent.
I can hear you too.
Okay, so good morning, everyone, and thank you for taking the time to attend our presentation today, as well as for sticking around till the very end. The Office of the Seniors Advocate is very excited to see our survey's raw data being released to a broader audience. My name is Rob Cowan-Douglas, and as Rick mentioned, I'm the Manager of Analytics with the office. I've been at the office a few years now and was closely involved with the deployment and release of the survey results. I want to take a bit of your time today to talk about some of the fascinating data linkage opportunities that exist with this survey. To me, especially for this survey, data linkage is a key element of interpreting and actioning the results from our survey. We have 10,000 resident and 10,000 visitor responses, but particularly for residents, we know there exists significant biases in who responded to the survey versus what the overall resident population looks like. And within those 10,000 responses, we know there's a great degree of variation in characteristics that might influence a person's perceptions of quality of life and quality of care. Before we get into some examples, I want to talk about what sort of data is available for linkage. The survey data resides in the Ministry of Health's data warehouse called Health Ideas. Within Health Ideas, all data is linkable via a common, unique identifier, a person's PHN or personal health number. If a person goes to the hospital or if they see their family doctor, that data can be linked together. If a long-term care resident is dispensed a certain medication, that information can be tied together with the PHN. Now, obviously, I'm trivializing the process here, but as many researchers would be accessing Health Ideas data, including our survey data, via data extracts prepared by ministry analysts, I think it's fair to paper over the nitty-gritty of lining up dates and service locations and so on. For those researchers who are directly accessing Health Ideas, the metaspace website that Ben demonstrated earlier is really, it's an invaluable resource in figuring out how you link data sets together. There's many coding examples, data dictionaries, et cetera, that make it a little bit easier. Within Health Ideas, there are dozens of data holdings. Some big ticket ones are the inter-RI assessments, both community-based and facility-based. The latter are probably the most important linkage for this survey data. Other major data holdings include hospital discharge records, pharmacy dispensing records, information on services performed under MSP, and information on medical practitioners. Metaspace is really the go-to resource for understanding what is held within Health Ideas, and therefore what you could conceivably link up with survey data. One of the really neat things about this survey is that its census approach allowed us to test many common quote-unquote truths of aging and long-term care. I think anyone who's been around the health system knows the branding power of the word dementia. I think it would be taken, as many of our presenters have said, as a given that most people with dementia would not be able to answer a survey. I know that both Ms. Mackenzie and Dr. Sawatzky touched on this earlier, as did Dr. Russell. The Intervi developed survey instrument we adapted to serve as the long-term care survey instrument carries a big warning sticker on the front. It says there's no point surveying people with a CPS score of 3 or more. The CPS, or Cognitive Performance Scale, is a 7-point scale assessing cognitive impairment. Now, how many people in long-term care have a CPS score of 3 or more? Quite a lot. 2/3 of residents would be considered not worth approaching if we followed Inter-RI's instructions for this survey. Our surveyors did not accept that. Seniors Advocate did not accept that. Dementia and its symptoms vary day by day and even over the course of a day. We went back 3 times to each resident to try to get a meaningful response from each resident. What did we find? We found that when we validated the responses of cognitively impaired residents and facilities against their less impaired peers, we found that the survey instrument was valid up to a CPS score of about 3. That's 89% more residents eligible to respond to the survey, and we've just seen several presentations attesting to this fact. However, another interesting thing we found was that we did have a handful of responses from residents assessed with a CPS score of 6, which indicates a comatose state. No way you're getting an answer out of them. This type of finding is a reminder of 2 of the caveats with the Inter-RI data. It is not necessarily timely, being captured on a quarterly basis, and is subject to a degree of subjectivity on the part of the assessor. Another assumption we were able to test was around food costs. A bit of backtracking might be useful here. The OSA utilized its existing product, the Quick Facts Directory, which we talked about a little bit earlier, as a vehicle on which to publish LTC survey results. For those of you who are not familiar with it, the Quick Facts Directory is our annually updated online directory of publicly subsidized LTC facilities. As of today, that is 295 facilities. We provide the public with information on ownership, build date, room configuration, licensing infractions, high quality indicators, funding information. Basically, we pull together a huge array of disparate information that would be a nightmare for the general public to find, and we present it nicely in a single place. One of the metrics we published has received quite a lot of attention is the raw food expenditures amount. This is the facility's self-reported expenditure on raw food inputs. This is one of those metrics that, at first blush seems easy to interpret, but actually needs a ton of qualifiers around how you interpret it. Nevertheless, there was quite a lot of demand for us to have a look and see if there's a connection between food expenditure and resident satisfaction with food. In our survey, we assessed food along 6 different questions. Probably not a big surprise to anyone who's operated a long-term care facility, but there's no correlation. I think findings such as this are really important because they push analysts to dig a little bit deeper to make that aha connection in why we see this result. In this case, it paves the way for understanding more about food cost. For example, you can have high food costs because you're in a remote area. Fine, that makes some sense. But you can also have high food costs because you're buying expensive prepared ingredients, such as peeled potatoes. And this leads to the conclusion that food cost is probably not the best metric for judging food quality in a facility. One of the analyses we did early on, and one that underscores the need for careful consideration of control variables in any modeling involving our survey data, was to link survey results with ADL scores, or activities of daily living, getting out of bed, personal hygiene, going to the washroom. We don't expect the majority of long-term care residents have some degree of impairment in these areas. But impairment, it's a spectrum. Needing someone to help you balance when standing up is quite a lot different than needing someone to physically lift you out of bed and dress you every single morning. Higher ADL impairment means more reliance on the care home staff. If you're relying on care aides to accomplish those basic tasks, your impression of what is timely and what is attentive might not only be different, but the immediate impact to your quality of life may be more pronounced than someone who has less reliance on the care aides. We observed significantly less positive impressions in the areas of staff responsiveness and personal control when we stratified by ADL impairment. Residents with higher degrees of impairment were progressively less likely to be satisfied with aspects of life surveyed across these dimensions. It is our hope that analysts and health authorities, researchers at universities, and so on are going to have much easier access to one of the largest LTC surveys ever undertaken. And because it's in health ideas, the data linkage experience should be vastly improved. As I mentioned earlier, data extracts prepared or provided to researchers generally arrive in a ready-to-go state. Those linkages have already been made, or at the very least verified. I can also personally attest to assisting in significant cleanup of the survey data to ensure that people accessing the data do not need an encyclopedic knowledge of the long-term care system to ask meaningful questions of the data. This is the cleanup that I discussed after Ben's presentation. We've put in a lot of work to clean up the names and identifiers so that you can link to other dimensional tables without a lot of pain. What I've talked about today are just a few of the examples where the OSA has leveraged the incredible depth of information in the inter-eye assessment to wrap context around long-term care survey data. I can genuinely say that we're really excited to see what sort of questions researchers out there might ask of our data and what sorts of insights can be gleaned. Thank you very much for your time, and I know we're pressed for time here. We can always be contacted at this email address. We're happy to talk about anything related to the survey, as well as providing, for example, our quick facts directory information to researchers.
Terrific. Thanks very much, Rob. It's super inspiring and perfect closure of our research or analysis exemplars. Very inspiring to see how this data could be used and linked with other data sources. But like you said, we need to move on. So I'm going to turn it over to Lena, I believe, for a wrap up.
Yeah, so thank you. What an amazing array of presenters that we've had, and thank you, Rick, for your facilitation. I hope that all of the analysts, the researchers, and others that are on the call today have been inspired. Thank you to Ben for doing the walkthrough on metaspace and the sample queries. We are really keen to hear your feedback on the tools and the toolkits and the information that we've developed to assist you with your analyses. We're open to feedback about the session, and most importantly, we would like to hear from you about what you need going forward. And so I've heard from all of our presenters today an invitation to contact them if you have questions. But I guess what I'd like to say is start exploring the data. And I know we've got Kelly Sanderson on the call with us today, and I know that Kelly, you'd be happy to entertain questions related to data access requests through Pop Data BC as well. Can I just ask you to validate that for us? Kelly, are you still on the phone or still on the call? Kelly. I see she's muted. Anyway, oh, there she is. Hi, Kelly. I just thought I'd give the last word to Pop Data BC. Okay, well, not hearing Kelly. I'm sorry if she's trying to speak and she can't be unmuted, but I just want to reiterate that I'm really grateful to everyone who called in today. I'm sorry that we didn't have enough time to, field more questions from our presenters, but as I indicated, everybody is keen to provide support to analysts and researchers who are interested in using this database. And so I hope you'll consider today a beginning, not an end, but a beginning to a rich data set that's now available. And we look forward to hearing from you. So thanks again, everyone, with a big thank you to everyone who presented today. And I think that Isobel Mackenzie's vision will be fulfilled when we see further work done with this rich data set. So thanks, everyone, and bye for now.